So many families, when first embarking on their embryo adoption or donation journey, wonder if the quality of their embryos affect their FET success rates, or maybe even wonder how are embryos created and their quality determined. Today, we're hearing from Dr. Allison Rogers about embryo quality and cryopreservation and how it affects your embryo adoption or donation journey. Dr. Rogers is a reproductive endocrinologist at the Fertility Centers of Illinois and has many years of experience in the IVF and fertility world. She has even helped some embryo adopted families with their frozen embryo transfers and has very informative and fun Instagram and TikTok accounts that center around fertility and IVF. She has graciously agreed to help us with this presentation so that families considering embryo adoption or donation have the most accurate answers to their questions concerning embryo quality and transfer success. So with that, I will turn it over to you, Dr. Rogers. Thank you so much for doing this with us today.
Thank you so much, Paige. I really appreciate it. So I'm at the Fertility Centers of Illinois. I'm a double board certified reproductive endocrinologist and OBGYN. And I have been out in practice about 10 years. And I was a fertility patient myself. So not only was I am a doctor, but I also was a patient, and luckily was successful on my journey. And my goal, of course, is to educate everyone who's trying to build their families about options. And the more educated you can be, the better decisions you can make about your health. Okay, so we're going to run through what the IVF process is like. So this is how we create embryos. And obviously our goals are to help build families, create life. And we start off, of course, by needing three things. We need the egg, we need the sperm, and we need a uterus. And those, of course, don't need to be from, the egg and the uterus do not need to be from the same people, right? So we give medication. So if you look at step number 1, we give medication to women. Those medications are usually given for about 10 days. So not a super long period of time. And during that time, we do ultrasounds and blood work to watch the follicles grow. Follicles are the little sacs on the ovary that contain the eggs. After about 10 days of medication, we give a medication called a trigger, and that trigger will mature the eggs inside the follicles. And what we do then is an egg retrieval. And that's what you see there in number 2, the transvaginal egg retrieval or oocyte retrieval. We give sedation for that, so patients aren't feeling pain. It takes about 15 minutes. So it's a brief procedure. We use the internal ultrasound probe, and we use a small needle to collect the eggs out of the ovary. It's kind of like getting your blood drawn, just deeper, so you want to be asleep for it. We then will mix the eggs and the sperm together. There's a couple different ways that we do this. Sometimes we will, as you see there in number 4, we can inject the sperm right into the egg. That's called ICSI, or intracytoplasmic sperm injection. We do that a lot, but not always. Sometimes we sort of just mix them in the dish together. We then grow the embryos in the laboratory. And if you can look at number 5, the embryo starts as 1 cell and then starts to divide, and it becomes 2 cells one day after it's been fertilized, 4 cells, obviously, and that keeps dividing. By around most embryos are 5 to 6, grown for 5 to 6 days, sometimes 7, sometimes 3, but averages, usually it's 5 to 6 days. And it becomes what we call a blastocyst. And a blastocyst is about 200 cells. And the inside part, I'm going to show you a picture of it, but the inside part of a blastocyst, so this is what it looks like here. And the inside part of a blastocyst here becomes the baby. And this outer part here becomes the placenta and the membranes. And once it hits this blastocyst stage, it can be transferred to a uterus, or it can be frozen. And so obviously a lot of our snowflake embryos are frozen at that stage and, able to be adopted. And when you receive those embryos, they are cryopreserved and frozen. And it really doesn't matter if they're frozen for days, months, or years, but those are frozen and sort of waiting for their new home. We are able to thaw them and prepare the uterus that they're going into, and then we do the embryo transfer. So for couples who are doing embryo adoption, they sort of come in at that step 6, where we prepare the uterus, we do the embryo transfer, and then actually 10 days after the embryo transfer, we're able to check a pregnancy test. So this is a little bit more in depth about embryo development. So the next day, we're able to see what we call a 2PN or 2 pronuclei. You can see that there are 2 little circles on the inside that look almost like, I don't know, glasses or something. Those are the DNA from the eggs and the sperm. And that's how we know that the egg fertilized and fertilized normally. There are 2 pronuclei there. If you can also see, there's an outer shell layer, and that outer shell layer is called the zona pellucida. And there is some little, at around 12 o'clock, there's some like little cells inside there. And those are what we call the polar bodies. And we know that the embryo is ready and is fertilized normally when we see 2 pronuclei and 2 polar bodies. It's a little hard to tell in that picture, but that's what happens. We then start to watch the embryo divide. And on day 3, you can see that top right picture, the embryo should be 6 to 8 cells. Some embryos are frozen on day 3. It is up to the laboratory. Sometimes embryos are frozen and ready to be transferred on day 3. Obviously, then sometimes we do day 5 or 6. We don't usually do day 4. Why? Well, because there's a lot happening with the embryo at that stage. It is forming a blastocyst at that stage and sort of having a lot of changes. So it's not good to be transferring at that stage. Then by day 5 or 6, like I showed you guys, that bottom sort of around 7 o'clock, that little clump of cells there, that is that magic that becomes the baby. That outside area is what becomes the placenta and the membranes. And that's the time where embryos are either transferred or cryopreserved for future use. So when we evaluate you before doing a frozen embryo transfer, we use the term FET for frozen embryo transfer. We want to make sure the uterus that the embryos are going into is healthy. So there are several things that we can do to evaluate the uterus. So typically we do what's called a saline sonogram, where I put some saline into the uterus and do a 3-dimensional ultrasound looking for any problems with the uterus. So polyps, fibroids, scar tissue, anything like that. We often will do or talk about whether people want to do testing of the uterine lining. The endometrium is the lining of the uterus. Sometimes an endometrial biopsy or EMB, that's what that stands for. We can do a biopsy to make sure there's no inflammation or any other issues with the lining that we can see, precancerous cells, anything like that. There are also some tests available on the market, and not everybody needs this. It's really important to talk to your doctor, figure out if this is something that is important that you do. And it really depends on sort of your history and the journey that you've been on up to this point, and also sort of how many embryos you have, that kind of thing. But we can do some testing of the uterine lining where we more or less do a practice cycle. We call it a mock cycle, where we give you all the hormones your body needs and then do a biopsy. And in that biopsy, you're awake. It's like a 5-second cramp. I did a bunch today, so they're not super painful or anything. And we can look to see how many hours of progesterone your body needs, make sure there's enough good bacteria, which is that lactobacillus that we get in like yogurts and that kind of thing. Make sure there's no pathologic or bad bacteria that could cause inflammation or cause an embryo not to implant. And then the Receptiva DX looks for things like endometriosis. It looks for a marker called BCL6, and that is a marker where we can see if you've had endometriosis. And sometimes we would want to do treatment of, antibiotics or hormone treatment before doing a transfer. So that's why sometimes those tests are really important. In terms of other related blood work and labs, usually we just want to make sure that the uterus and the body the uterus is in is nice and healthy. So healthy pregnancy labs, so blood count, blood type, vitamin D levels. We want to make sure you're protected against some viruses that can cause birth defects like varicella, which is chickenpox, rubella, which is in that MMR vaccine. Those can cause pretty devastating birth defects. We'll make sure you're protected from your childhood immunizations, and sort of look at some hormone levels, thyroid, prolactin level, that kind of thing, really just to make sure your body is healthy and ready for pregnancy. So there's a couple different ways we can prepare your uterus for an embryo. And if you are someone who has perfect cycles, 28-day cycles, you ovulate on day 14, you have these really nice normal cycles, we really can just use your body's natural cycle of preparing your uterus for a pregnancy. And we watch the follicles grow. A lot of times we either tell your body to ovulate, or we can tell when your body ovulated, and then we time out the time of the transfer perfectly. The other option is a hormone replacement cycle. And I think this is what most clinics do. We give you the medications to really emulate a natural cycle. So we give you all the hormones your body needs. So if you're somebody who maybe doesn't get normal cycles because they're, maybe they have polycystic ovaries, or they have something like hypothalamic amenorrhea, or maybe your periods are coming too soon, or you're getting spotting in between, something's happening where you're not getting regular cycles, then we definitely want to use a hormone replacement cycle. So I just want to go over some of the pros and cons of each of those approaches. It's really important you talk to your doctor about your situation. So the natural cycle, there's really no meds used. We really track the natural cycle. The benefits are we use less medicine, which is always a good thing. Some of the downsides are that our bodies are unpredictable. And so a lot of times there's not very much predictability in the timing of the transfer. And a lot of times, there's certainly a much higher chance of cancellation if the body's not responding to the medicine. In fact, I literally just canceled someone today who was trying this. And, because she didn't make an egg on time, she didn't ovulate strong enough, and then we needed to unfortunately cancel. So, so that's some of the downsides, that sometimes there can be a higher cancellation rate. This is really best, like I said, for people who have really consistent ovulatory cycles. That is a great option. And if you are somebody who has normal ovulatory cycles, your chances of success with the natural cycle or hormone replacement cycle should be the same. So it's not like one of these is better than the other. In terms of the hormone replacement cycle, this is, like I said, really the most common treatment that we do for frozen transfers. We use natural medicines. So we use like natural estrogen, natural progesterone, and we give you medications to perfectly time so that the lining of the uterus is ready to accept an embryo. The uterus is not ready to accept an embryo all throughout the cycle. There's a very short window, maybe even as short as 6 to 12 hours, where the uterus is able to have an embryo implant. And so it's really important that we control that perfectly, and that we can do that really easily with medication. Benefits, of course, it's very straightforward. We can plan it, we can schedule it. There's very little cancellation, but the downside is that it's a little bit more medication. It is all natural medication. You're not on it the whole pregnancy, but it is something to think about. So those are just some of the ways we prepare the uterus for that embryo transfer. I want to spend just a few minutes talking about what PGT is. So PGT stands for pre-implantation genetic testing. And this is a tool that we can use in some patients about testing embryos to see if they're genetically healthy. So not everybody uses this, and not everybody needs this. Some people may consider this if they are of older age, so at higher risk, for example, for having a baby with a genetic problem. Couples who are known to carry genetic disorders. So if you and your partner are both are carriers, for example, for cystic fibrosis, and you don't want to have a sick child, then that is something that sometimes people do genetic testing for. Recurrent miscarriages or recurrent implantation failures. And then sometimes patients just want to do it. And then there's some other, obviously a little bit more controversial reasons why people do it, like what we call family balancing or gender selection. Most people don't necessarily do this. Not everybody needs to do this, but some embryos certainly will come with that genetic testing already done. Most will not. And it's important to know that a lot of embryos do not need to do this. And it does not necessarily increase the chances of pregnancy unless the person who the eggs came from was significantly older. So it's really important that you understand that this testing is available, but not needed in every case. And once embryos are frozen, it can cause damage to the embryos to thaw them, biopsy them, refreeze them, and then rethaw them to use them. In fact, we see a significant decrease in the chances of pregnancy when we do this. So if you are getting embryos that are already tested, awesome. If you are getting embryos that have not been tested before, it's not anything you need to do later, because that can actually harm the embryo. So it's just important to know that that technology is out there, and that it shouldn't necessarily be done in hindsight. Some of the pros and cons to genetic testing. So obviously, for people who have a high risk of having an abnormal embryo, we can see that the embryologist can better pick normal embryos in people who have a really high risk. There is the potential for false positives and false negatives, so it's not perfect testing. So we can have an embryo that would have made a healthy baby and we could call it abnormal because of what we call mosaicism. So it is not, it's not perfect testing. And I think that there's some serious risks with it. So it's just important to understand what that is. Also, it's important to understand that most embryo adoption programs do not allow these tests to be performed after the donation process, obviously, because of the potential damage to the embryos that can happen. So let's talk about the chance of your embryo not surviving the freezing and thawing. Now, this really depends on the quality of the embryo and the technology used in the lab where it was frozen. So the day that the embryo was frozen will affect its ability to survive. So, the embryos do have a very high chance of success. It's probably about a 98, in my lab, it's probably like 99.9 chance of success of surviving the freezing and thawing. And that's because we use a really high technology type of freezing called vitrification. And if you have embryos that were frozen like a long time ago, maybe 10 plus years ago, there may be some different freezing techniques that were used. But I think most of the embryos that are going to be received are vitrified and have a very, very good chance of success. So if you have a scenario where you're showing up for your embryo transfer and you're putting in one embryo, and for some horrible reason that embryo doesn't survive, that embryologist is able to thaw another embryo, should you have another embryo, thaw another embryo right then and there. So your cycle does not necessarily need to be canceled or anything like that. But if an embryo doesn't survive, they can thaw another one. It does not happen very often, luckily. And there's a really good chance at surviving and doing well. Okay, so I'm going to talk about a couple of things. So your chance of pregnancy truly depends on the age of the woman at the time that the eggs were taken out of the body. So it's not based on your age. It's not anything related to sperm. It's related to the age of the egg source. And each clinic has different chances of success. For women who are under 35, there's this is in general, this is looking sort of nationwide. My clinic tends to have a much higher chance of success, but this is sort of, you look at like all over the country, they pool the data from all over the country. This is sort of in the United States, what do we see? So women under 35 have about a 65% chance of pregnancy with a low miscarriage rate. As we get into our later 30s, we see a higher, a little bit lower chance of success, but still really high, slightly higher chance of miscarriage. I always think about 40 is like easy to remember because it's like a 40% chance of success and a 40% chance of miscarriage. And then obviously as the woman gets older, and this is the egg source, so not the uterine age, but the egg age, the age of the person who's giving the eggs or the embryos, as those women get 42, 43, there's a lower chance of success and a higher risk of miscarriage. When we look at embryos that are tested, it kind of evens the playing field. So you can see that there's not really a huge difference for women who are younger, but for women who are 42, 43, the genetic testing does increase the chance of success because we know we're putting in a healthy embryo and does reduce the risk of miscarriage. So it's just important to realize that sort of this data and the chances of success do vary based on the age of the person whose eggs were used at the time that they donated them. What can I do to have a successful transfer? So the truth is that part of it is out of your control. In fact, most of it's out of your control, and it depends on the health of the embryo and the health of the uterus, which is why we do all this testing of the uterus and the preparation of the uterus beforehand. And so things that you can do to sort of make your body the healthiest it can be, because it's not your fault, you can't make it work or not make it work. It's going to work if it's going to work because of the embryo in the uterus. Unfortunately, you and the doctor, me, I don't have as much control as I want either. So we think about healthy social habits. So we think about alcohol use. We want to limit it. Of course, no, you should not be drinking alcohol after an embryo transfer. And then before the transfer, you don't want to have more than 2 alcoholic equivalents in a 24-hour period for women, 3 for men. And an alcoholic equivalent is a can of beer, a glass of wine, or a shot of alcohol, a shot of liquor. So it's sort of important to realize that. Of course, cutting out things like nicotine, marijuana, and then things we don't necessarily think of are as drugs, but things like caffeine. We love our coffee here in the United States, and it's important to keep it less than 300 milligrams of caffeine. I usually recommend keeping it under 20 ounces. That is, 2 home cups or maybe 1 venti, but I wouldn't do more than that. Exercise is really important to keep your body healthy, both cardiovascular exercise to keep your heart and your blood vessels in shape, as well as resistance exercise to keep your bones healthy. So those are both really important. After embryo transfer, you should talk to your doctor. In fact, I have an Instagram post that I've written that needs to go up soon about this, because I get lots of questions about what exercise people can do after an embryo transfer. And part of that is going to depend on if you had a natural cycle transfer or a hormone replacement cycle. And usually we'll say sort of no high impact exercise after the transfer. Usually before the transfer, you can do whatever you want. But it is important to sort of maintain health. Having a normal BMI is important. We do know the medicines don't work as well with higher BMIs, and embryo transfers don't work as well. So having a normal BMI is important, not only for getting pregnant, but having a healthy pregnancy. We know that women who have a normal BMI, and it's not about a number on a scale, right? It's really about sort of what happens when we carry extra weight. We think about problems with, higher risk pregnancies in terms of things like preeclampsia, gestational hypertension, gestational diabetes that can really affect the success and health of a pregnancy. So that's one thing. And then of course, nutrition. I recommend that patients consider having a nice balanced diet. You want to make sure you're eating the rainbow. That picture is a great representation of what the rainbow represents. If you are someone who's vegetarian or vegan or dairy free or whatever, that's okay. It's just really important to make sure you're getting all the important nutrients. So taking a prenatal vitamin and making sure you're eating lots of fresh fruits and vegetables. I usually recommend patients, if they can, try to eat as much organic foods as possible to really limit any extra chemicals, limit any processed foods. So eating as much whole foods as possible to minimize processing. And, when we think about sort of organics, sometimes we think about fruits and vegetables, but also looking at sort of meats and grains, because if you think about grains, those were at some point vegetables that have been sometimes sprayed with chemicals. So we want to really look at sort of all of our dietary habits. And it's important not to be too hard on yourself either. Obviously you want to, be the healthiest you can be, but you also want to have some grace with yourself. So we're going to go through some questions now. This is the information to get a hold of snowflakes. And if you look on the left there, that is my Instagram and TikTok. So you are welcome to follow along.
Yes, and they're really, really fun, everybody. So please go give her a follow, especially her TikToks.
Thank you.
We do have some questions from a social that we gathered off social media, and just questions that we've heard in general from families who are thinking about embryo donation and adoption. One of the main ones is that we do have some families that do opt to adopt slow frozen embryos. Can you talk a little bit about the success rate of embryos that were slow frozen, like 10 or so years ago? Because that was more common back then.
Yeah, so like I said, the slow freezing technology was the predominant technology for years and years and years, and really only became sort of the main freezing technology within the last 10 years. And it used to be the day 3 embryos, and then it was only vitrification, which is the newer technology, was only used for blastocysts, and day 3s were slow frozen. So it is absolutely possible that you can have embryos that were slow frozen. And I think the longest time an embryo has been frozen and created a baby, I want to say, is like 28 years, which is like awesome. And it was a embryo adoption family who had a baby and then had a sibling from the same cycle. That was a long time ago. So I don't even know if it was one of yours or not, but it was a really awesome story that gave a lot of hope. I think that the chances of the embryo surviving the thaw are going to be less. It's important to know that they are going to be less, but not, you know, super, super low. It really depends on sort of the skill of the lab that froze them. And again, the health of the embryo. So I would say if the chances of surviving the thaw for vitrified embryos are like 98% overall, I would say that it's probably closer to 65 to 70% with slow frozen embryos. So that's also the scenario also where if they are slow frozen and an embryo doesn't survive, if you have other embryos, they can be thawed sort of right then and there. So your whole cycle doesn't need to be canceled.
Yeah, and then the other question we had as well about slow frozen embryos is, are there some clinics, or do most clinics, I guess, do they not take slow frozen embryos, or like, do some labs just not have the ability to work with slow frozen embryos?
That's a good question. I mean, I would hope that any lab that you guys are partnering with would be happy to take those embryos and give them a try. I think that most labs should have, like, the technology is easier. So it seems like your lab should be, you know, pretty able to do it. If they're not, there are other labs that are willing to do those for you. So if you sort of have the ability to get frozen embryos, I don't think you need to shy away from them. It's just, you know, it's important to understand that it's not technology we're using a ton right now for embryos. Now we're using it a lot for sperm and other things, right? We use it for sperm still a lot, but it's just important. So we're still using that technology. We're just not using them for embryos as much because they don't survive the thaw as well. So, but there are clinics that will help you.
And then this one, the next couple we got from Facebook here. So this one, I've never heard of this before. And it's like, what is the success rates of slow growing embryos?
So I think what they're talking about is, so we expect embryos to be sort of meet certain milestones. So we expect them to be 6 to 8 cells on day 3. And by day 5, we expect them to be sort of at least what we call like a morula stage, which is sort of the stage right here. I'll show you. It's like, so you can see that these cells are like really, you can tell they almost look like gumballs. And then by it's here, the cells start compacting where you can't really see individual cells right there. So we really expect them to be, we like them to be here by day 5. But sometimes it takes them like 6 to 7 days to get there. So we know that embryos that are full blastocyst by day 5 do the best. Embryos that are slightly slower growing still have the potential to be successful, but have a slightly lower chance of success. So embryos that are not full blastocyst until day 6 or 7 do have a slightly lower chance of success, maybe by like 10 to 15%, but they still have the ability to make beautiful, healthy life.
And then the other one we got from Facebook is there any change in success rate based on the freezing process of, and they said vials versus straws. I've heard of straws. I don't think I've heard of vials before.
So usually we use vials for sperm. We use vials for sperm. We don't use, and then we use straws for embryos.
Okay.
You know, I think that the embryos are small and we usually freeze just like 1 or 2 in a straw. Yeah. And so it's just a different way, it just, because the volume of fluid is so much less, with they're frozen in an itty bitty little straw. And the vials are, like little vials of fluid that contain a few milliliters, and that's usually better for sperm.
And then the other one, which I think you went over already, but if you can touch base on it again, is the grading of the embryo. So like AA versus like BB, is that an indication of the ability to actually have the embryo implant?
That's a great question. So let me explain. So there is no unified grading across like the United States or the world. So every clinic does it different, which is a little hard when you're like, in a program like snowflakes where we're like looking at embryos from all over the place, but usually we can figure out, what grading system. They'll tell us what grading system they're using. And the first letter, I'm going to show you this picture of this blastocyst here. So the first letter we use indicates the health of the inner cell mass that becomes the baby. The second letter we use indicates the health, and this is literally just a beauty contest. It's literally what we're seeing under a microscope. So it's not about the genetics or anything like that. We're looking at the trophectoderm, which becomes the placenta. A lot of times embryos are given a letter grade. I feel like the top of my head is getting cut off here, sorry. The embryos get a letter grade. Some clinics, you can see the difference here between this embryo and this embryo is an early blastocyst. This is a fully expanded blastocyst. So some clinics will give this a grade 1 and some clinics will give this a grade 1. So is one the small or the big? And every clinic's different. So my clinic says 1 is the best and 5 is the smallest. Other clinics, 5 is the best. So that's where it's really confusing. And we got to the lab and the doctor should be able to tell. So just because everyone's different doesn't mean we won't be able to know the difference. We'll be able to know, but just looking at it yourself, you may not know whether, a 5AB is awesome or horrible, right?
Yeah.
But the doctor should know. I also think that every lab grades the A, B, C on how healthy the embryo is a little bit differently. So I work with 2 laboratories, one in Chicago and one in the suburb of Chicago called Highland Park. And I know that for example, BB embryo in Chicago is probably the same as a CC embryo in Highland Park, just because they grade it a little bit differently. And that's not something that you would know if you're just looking at it, which is why I think at some point we need to have some unified ability to grade embryos, but that's just not there right now.
Yeah.
So it's important to talk to your doctor about the embryos. Usually A's and B's are really good. And what I see in my clinic is that anything with an A, so AA, BA, AB, those all do the same. So an AA and an AB, they do the same. And it's not until we get to the BB that they do slightly less. And it's not necessarily even about sort of the genetics of the embryo. Obviously, we can't tell that by looking at an embryo. It's also about sort of the metabolics or how the embryos are able to grow and implant. So there's multiple sort of reasons why embryos are successful or not. Grading kind of just gives us a clue. So better graded embryos we usually use first because they have a better chance.
Mm-hmm. Right. Yeah. And I tell families all the time when I'm talking with them, we don't send you the embryology, because a lot of families will say, well, can I see the embryology report? I'm like, well, you're not going to be able to understand it because it's completely different between your clinic that you've been using and the clinic you might be having your transfer at. And
yeah, and that's where as a physician who I not only send a lot of patients to snowflakes, but I also accept a lot of embryos from snowflakes and work with couples who are using snowflakes, is I'm able to look at that report and say, oh yeah, these are great embryos, and we should, my embryologist and I will work on what embryos should be used first based on the best quality.
And then this one actually came from Instagram. So she said, I'm 43, that I adopted embryos from a genetic mother who's in her mid-30s. Mm-hmm. Am I more likely to have a more successful FET even though I'm 43?
Yes. So I will say 35-year-old egg embryos, embryos that came from a 35-year-old versus 43-year-old, the 35-year-old, there is a huge drop right around 38, where, success rates drop pretty significantly. And 35, the chance of success with that donated embryo is going to be so much better than 43. Most women lose the ability for their eggs to create life somewhere around 42, 43, 44. Everyone's different. It's not like there's any test we can do to totally know, because usually people have eggs, just not healthy eggs. So, but usually 35 is a great age, to have embryos from.
Yeah. And then we have one more question, which I like this one. Does acupuncture really help with FET success?
So that is a fantastic question. So I'm a big fan of acupuncture, and that's because there's a lot of science about it. Let's talk about what the science says. So when you really dig deep and you look at acupuncture, it does not, unfortunately, increase the chance of success. So when we look at groups of people who did acupuncture versus didn't do acupuncture, there's not an increase in pregnancy rate or take-home baby rate, which is really what we care about, right? The chance of having a baby to bring home with you. There's not an increased chance of pregnancy or take-home baby rate with acupuncture. That being said, this whole process can be really stressful, as most people watching this probably know, and it's a lot to go through. And having all of your resources, all of your support, whether it's friends and family, therapy, clergy, acupuncture, massage, like all of these tools you have in your toolbox help support you and help manage stress, the better. And so people feel better when they're going through treatment, when they're doing acupuncture, which is why. But people shouldn't feel bad or guilty or like their transfer didn't work because they didn't do acupuncture. I am a big fan of it. I recommend you could try it. I loved it when I was going through fertility treatment, but it's not for everybody. So, I think that the science is there showing that people emotionally feel so much better. And also things like meditating, yoga, like all of those mindfulness, techniques, but it does not, unfortunately, improve pregnancy rates.
All right, well, that's all the questions we have for today. Like we said, follow Dr. Rogers on Instagram and TikTok. It really is entertaining. She does this little thing called Sperm Mondays where she looks at sperm samples, and it's very, very interesting. If you have any questions about snowflakes or embryo adoption, our contact information and website are right there. Do you want to leave everybody with some final thoughts, Dr. Rogers?
So if you're watching this video, you're on your fertility journey, I would encourage you not to give up. You're taking one step closer to your baby, and you will be a parent. Your baby will be there, and just keep going and you will be successful. There's a lot of pathways there, and obviously embryo adoption is an amazing opportunity.